evening and a very warm welcome to all the respected doctors who have joined us this evening for yet another interesting session in the series of NEFFRON, an expert curated lecture series for physicians who deal with kidney disorders in their day-to-day practice. So today, I would like to introduce our clinical expert for the day, Dr. Rahul Deshpande. So without any ado, I would like to share some insights about Dr. Rahul Deshpande. He has over 10 years of experience in the field of nephrology. He has done his DM nephrology from a prestigious institute, KM Hospital, Mumbai, and has also cleared his DNB nephrology along with DM. He has worked in high volume institutes like KM Hospital, Mumbai, and also worked as an associate consultant in HN Reliance Hospital, Girgaon. He has vast experience in handling all outpatient departments, inpatient departments, and ICU based critical nephrology cases. He has been associated with hospitals who are very renowned and prestigious all over Mumbai and in suburban Mumbai, such as SL Raheja Hospital, Criticare Hospital, Surya Hospital, and Guru Nanak Hospital. And today, Dr. Rahul Deshpande is going to share his insights on a very important topic that is much ignored in the day to day practice, that is hyperuricemia, what, when, and how to address. I would like to invite Dr. Rahul Deshpande sir now to address the audience and take over the session.
Yeah. Thank you very much. Thank you very much, Anjali ma'am, for such a nice introduction. So, shall I start the sharing?
Yes, sir.
So, hope the slide is visible.
Yes, sir, it's visible.
Yeah. So, the today's topic that we will be discussing is a hyperuricemia. So rather than a disease, a hyperuricemia, what I will say is a abnormality, is a metabolic abnormality where there are two doubts, means not just about whether to treat or not, but also when to treat and how to treat. So that is
Sir,
the two. Yeah.
sorry to interrupt you. Your video is not visible, sir.
Sorry.
Yes,
Yeah.
sir, it is visible now.
Yeah. So, as we discussed, so what is hyperuricemia? So, the definition of hyperuricemia is the upper limit of normal range of uric acid levels more than 7 milligram per dl in men and 6 in women. So, hyperuricemia is basically whenever the uric acid level goes above these levels, then what happens is the blood gets saturated. At this point of time, there is a chance that the uric acid crystals or monosodium sodium urate crystals may get accumulated, where usually in the joints or in kidneys. Joints we call it as a gout, and in kidneys we call it as a uric acid nephrolithiasis or a uric acid stones. So basically, how the uric acid is formed. We will not go into the details of these things, but we should know this. I will tell you why at the last of the slide. So basically, as we know, there are nucleic acids like RNA and DNA in each cell nucleus that every living thing has. So there are two types of building blocks, what we call as a purines and pyrimidines. So basically, uric acid is nothing but the purine metabolism end product, which is uric acid. So why this is important to know? Because that's why whenever there are many causes of hyperuricemia that will come in a next slide. But whenever there is a massive cell lysis in the body because of anything like in malignancy, in a massive malignancy after chemo or everything. So there is a massive lysis of cells. Because of that, the nucleic acid is released, and because of that, hyperuricemia happens. So basically, it is a nucleic acid product. So it is inside the cell. It is reside inside the cell. So now pathogenesis of hyperuricemia or etiology. So basically, there is 10% over production and 90% under excretion. So now, whenever uric acid is formed, so basically there are two ways how it can get out of the body. So one is obviously kidneys, that is urine. So almost 60 to 70% of excretion is through kidneys, while just 30% excretion is through gut, that is GI tract. So overproduction, I will not say exact overproduction, but overproduction plus increase intake of uric acid. Just like we see in the slide, like dietary purines. So as we discussed, purine is basically a nucleic acid product. So obviously, whatever meat you have, it may be a beef, pork, lamb, which has more rather than the white meat. But even the red meat and white meat, it will all have a uric acid. So seafood and increase beer consumption, that will come under the drug category actually, that we will discuss afterwards. And endogenous purine synthesis, as I told in that first slide, whenever there is a huge malignancy load, large malignancies, metastatic malignancies, and after the treatment of any huge malignancy, which happens is a tumor lysis syndrome. So along with that, some enzyme deficiencies, which usually manifest in the early ages of life, like the enzymes which are supposed to form uric acid. So HGPRT deficiency and PRPS deficiency. Then the risk factor for this hyperuricemia is usually male more than female, older ages more than the younger, and obesity. Obviously, obesity, as the cell burden increases, the uric acid level also increases. This is the overproduction. So basically, if you eat more meat, uric acid will be more, obviously. If you have some cell lysis happening, so uric acid will be more. And under excretion, which is more important. So under excretion is that we'll be seeing in our next upcoming slides. As I said, most of the uric acid excretion naturally happens through the kidneys. So urinary excretion, which is disturbed because of diuretics or renal failure, then the patient tends to have a hyperuricemia. Urinary reabsorption increases because of alcohol. Just I mentioned, ethanol increases the urinary reabsorption. That's why again alcoholism leads to a hyperuricemia. So what next slide says? So how? So as I said, uric acid 70% excreted, almost 60 to 70% excreted through kidneys. So how this happens? How this slide is important because of this only you will come to know the next one. So 100% of uric acid is filtered through the glomerulus if the GFR is maintained. Obviously, if patient is not a CKD patient. So out of this 100%, again there is a tubular reabsorption, again tubular secretion, again reabsorption. So ultimately, only 10% of whatever is filtered through the glomerulus is excreted through the kidneys. Now what happens? So this is the next thing. So whenever there is increased reabsorption, means reabsorption of uric acids, it is filtered through glomerulus and it is reabsorbed through the tubules. So there are certain drugs and even the conditions like dehydration. It can be diuretic induced or other causes like vomiting, diarrhea, dehydration. So in all these cases, there is increased reabsorption of uric acid, and that's why hyperuricemia happens. Of OAT expression means organic anion transporters, which are supposed to secrete back the uric acid into the renal tubule and then it is excreted. So if there is something or some drug acting on that, so definitely there will be hyperuricemia. Just like as we mentioned, diuretic, any kind of diuretics. And hypertension, hyperthyroidism, obesity, and certain drugs. As we know, is some drugs, as we discussed, diuretic. Second is a well-known anti-tubercular drug, that is a pyrazinamide, which is well known to cause a hyperuricemia. So these drugs and many more, just like we discussed, because of chemotherapeutic agents, there can be a cell lysis, and again there can be a hyperuricemia. And obviously the last factor is the GFR. So if the GFR itself is a less, if patient is already having a CKD stage 3, 4 or an advanced CKD, then it will not be filtered at all. So obviously it will not be excreted and patient will have a hyperuricemia. Sir, so the next thing is hyperuricemia linkage with the comorbid condition. So basically, previously only this was thought that hyperuricemia means crystallopathy. Now, what is crystallopathy? Crystallopathy is basically having uric acid crystals, that is monosodium urate crystals deposition in the joints, that is gout. And second is, and after that, if the joint is damaged, that forms the tophi. But the second is uric acid crystals or stone formation in the kidneys. So these are well-known entity which are directly linked to hyperuricemia, and these are called as a causal. But afterwards, slowly, as per the studies and researches, we came to know that even this metabolic syndrome can be associated with uric acid. I mean, now you can call this as an association or as a causal, means whether uric acid is causing this or this is just an association that a metabolic syndrome ka part is hyperuricemia, whatever it may be. But there are some hypotheses and studies which we will see in next slides where we will understand these things. So basically, uric acid causes crystallopathy is well-known fact where there is a gout or a uric acid stones. And second thing is a progression of chronic kidney disease without forming stone in the kidneys, worsening of hypertension because of endothelial damage and multiple mechanisms, and increased CV risk, that is cardiovascular risk, is also known with a hyperuricemia. So that's why this is not something which we can neglect. So, so basically interrelationship of hyperuricemia, chronic kidney disease and cardiovascular disease. So as we see, because of hyperuricemia, that is well-known SMC proliferation, means smooth muscle cell proliferation in the vessels. Along with that, there is increased RAS activation. RAS means because of the action of uric acid on the kidney, there is increased renin-angiotensin system activation, which itself is known to cause vasoconstriction in overall body. So vasoconstriction. Third thing is COX-2 cyclooxygenase inhibition because of hyperuricemia. Fourth is because of hyperuricemia, there is a inhibition of some substances like nitric oxide, which are well known to be a vasodilator. So all these things lead to a continued vascular damage. So basically, which ultimately ends up in having a systemic hypertension as well as glomerular hypertension, endothelial dysfunction and cardiovascular disease. There is obviously endotheliosis is there and vascular damage is there. So cardiovascular risk is also increased, and the vasculature in the kidneys are also affected at the same time. So there is a renal disease progression also. So tissue hypoxia, cell death because of all this endothelial dysfunction and vascular damage. And ultimately, because of cell death, again a release of purine and hyperuricemia. So this is a vicious circle that we have to break at some point. So now, first we saw what is hyperuricemia, a basic idea how it goes and how from where the uric acid comes. Now the second thing is hyperuricemia and chronic kidney disease. So now how are they linked? So basically, uric acid is supposed to be a major independent risk factor for development and progression of renal disease. So progression of renal disease is well known. Development of renal disease is slightly dicey unless and until it is a proper uric acid stone or a crystallopathy. But still, as per studies and researches, hyperuricemia itself is an independent risk factor for development of CKD. And also the progression. Progression is well known. Progression, if not, if a patient who is already having a existing chronic kidney disease, hyperuricemia is to be taken care slightly more seriously, to be frank. Hyperuricemia is common in CKD and may occur because of decreased excretion, increased and combination of both mechanisms. So prevalence of hyperuricemia rises in parallel with GFR decline, which is present in 60% of patients with CKD stage 1 to 3 and 70% stage 4 and above. So obviously, as we saw in our first few slides, that most of the uric acid is excreted through the kidneys. So whenever the GFR goes down, that is a later stage of CKD. So obviously, just like the potassium, water, and uric acid and metabolic acids all are accumulated, similarly, the uric acid is also accumulated in the blood. So here, what I mean to say, the latter stages of CKD, the hyperuricemia is very common. That should be seen and treated. And again, hyperuricemia causes further kidney damage, and kidney damage causes hyperuricemia. So basically, how hyperuricemia causes a chronic kidney disease. So what is the theory behind it? What is the rationale? So basically, uric acid crystals adhere to the renal epithelial cells, and they induce the acute inflammatory response Forget about kidney stones. That we all know. Any kind of stone, it may be a calcium phosphate, calcium oxalate, urate, or cysteine. But irrespective of stone formation, there is a direct damage to the kidneys. There are various mechanisms. Few we have already seen, few we'll see in next slides. So, includes induce oxidative stress, endothelial dysfunction, and systemic as well as glomerular hypertension, which both are known to cause a reduced kidney function over the period of time and development of CKD. So basically, this is how it goes. So mechanism of hyperuricemia which can contribute to development as well as progression of CKD is, as we discussed, it causes reduced nitric oxide bioavailability. So no nitric oxide, there is a vasoconstriction, not just at a systemic level which causes hypertension and CV risk, but also at kidney level. So by acting on a kidney level, there is a glomerular hypertension. Stimulation of oxidative stress because it is a pro-inflammatory. Uric acid is a pro-inflammatory. So it causes multiple things like secreting multiple neurohumoral things which can cause a fibrosis in the kidney. Activation of RAS, renin-angiotensin system. So whenever this renin-angiotensin system is activated, there is supposed to be a kidney damage because of hyperfiltration theory. The same thing happens in a hypertensive kidney disease. The same thing happens in a diabetic kidney disease. The GFR first increases, and because of hyperfiltration, the further nephron dying happens and the CKD happens. So systemic as and glomerular hypertension, tubulointerstitial inflammation and fibrosis. So this is how the hyperuricemia can turn into a CKD and even worsen the CKD progression. So observational studies in which normal asymptomatic hyperuricemia, that we will discuss, that is the interesting point to be discussed. So there are multiple studies, and you can see the sample size is huge, where 1,77,000, 48,000 healthy Japanese, Austrians, and there are many. So here, if you can see the findings, the risk of chronic kidney disease is 2 times higher if uric acid levels are higher. The ESRD chances in someone who has already established CKD are 3 times higher. The risk of CKD incidence was 63% with uric acid more than 9, and while it was just 26% if uric acid was 7 to 9. So basically, what I mean to say is, in general population, higher levels of serum uric acid level confer greater risk of incidence of CKD and CSRD, means CKD and progressing to ESRD or dialysis dependence. So diagnosis of hyperuricemia, we have seen what is hyperuricemia. We have seen hyperuricemia and CKD, and now hyperuricemia and gout. So what is gout? So basically, high uric acid level, along with that a typical presentation, which is basically a clinical diagnosis. It can be proven by doing the biopsy or aspiration of the joint, but it is a clinical diagnosis where most typical presentation is a onset of monoarthritis, generally affecting the metatarsophalangeal joint of the foot, where there is redness, inflammation, swelling, and severe pain, which lasts for 7 to 14 days and goes only to come back unless and until the hyperuricemia is taken care. So, with multiple flares, the joint gets deformed, and there is formation of tophi and formation of a permanent arthritis in the joint affected. So basically, this is the same slide. So normouricemia, hyperuricemia. Because of hyperuricemia, there is a reduced solubility of uric acid, which gets accumulated in the joint spaces, especially the metatarsophalangeal joint is the most common. Other joints are also known to be involved as a monoarthritis complex. So because of that, recurrent gout flares associated with pain and inflammation, and if not treated, then it can cause a gouty arthritis and tophaceous gout and deformed joint. So diagnosis, the ultimate diagnosis is obviously synovial fluid aspiration and microscopy to see for a monosodium urate crystals. This is the confirmatory test of a gout. There is something called as a pseudo gout also, where calcium pyrophosphate, which can be easily proven by the synovial aspiration. So now the next thing is, so we have seen hyperuricemia and crystallopathy. Crystallopathy means kidney stones, and gout, that is accumulation of crystals. So in these two situations, that is well-known crystallopathy, there is no doubt that uric acid level has to be maintained as less as possible, preferably at least less than 6. So to avoid a further flare of gout and further stone formation in the kidneys. This is well-known fact, and no one will disagree to that. The problem comes is whether asymptomatic hyperuricemia should be treated or not. So there are some evidences where there is a link between increased uric acid level and onset of CKD. So as we discussed previously, but still treating asymptomatic hyperuricemia is not recommended as per guidelines up till now. However, in patients who are having existing CKD, lowering uric acid levels may retard the progression of CKD. Just like what we do for retarding progression of CKD to control the pathogenesis, means patient is diabetic, hypertensive, to control the BP, control the sugars. So this comes the next, that uric acid level also has to be kept in check. So these are the further trials that benefits of urate lowering therapy in CKD patients. So everywhere you can see, which I have highlighted, reduction in CKD progression, slowing of eGFR decline, and uh, lower adjusted creatinine when ULTs were used. ULTs means uric acid lowering therapies were used. So asymptomatic hyperuricemia, treat or not. Although ULT has shown evidence in slowing down the progression of CAD, there are no clear confirmation of use of ULT in asymptomatic hyperuricemia. More clinical trials are required to confirm the safety and efficacy. Several guidelines recommend starting ULT at more than 9 milligram per DL of uric acid levels. Some say more than 10. So after considering the risk versus benefit ratio. So even that simply means symptomatic hyperuricemia or a crystallopathy have to treat. Asymptomatic hyperuricemia more than 9 or more than 10 should be treated. So what options do we have whenever we call about treatment of uric acid hyperuricemia? So there are many, like uricosuric agents and whatnot. But to be frank, the most prominent are xanthine oxidase inhibitor, what we know. So basically, the most prominent since decades are the two that are allopurinol and febuxostat that we well know, that are well known. The newer is the topiroxostat. So xanthine oxidase inhibitor remain the first line of treatment by all guidelines. Allopurinol and febuxostat are the two prominent and older molecules. The topiroxostat is relatively new. So comparing allopurinol and febuxostat. So obviously, whenever we are comparing about two drugs, the two main things to be discussed are efficacy and safety. So as far as efficacy is concerned, so uh, to be frank, both are more or less equal as far as efficacy is concerned. But we will see in next some slides what other studies and researches say. So allopurinol, uric acid level starts reducing in 24 hours, and max effect is in 2 weeks. That's why after 2 weeks, the dose can be adjusted. So the allopurinol dose is to start with 100 milligrams BD, increase to 100 milligram TDS. Maximum dose is 800 milligrams. And while for febuxostat, it is around 80 milligrams in a day, which should be titrated over the period of time. Now, what is the issue with allopurinol is basically allopurinol is metabolized into oxypurinol, and this is an active metabolite of allopurinol. So this has to be excreted through the kidneys. So whenever there is a reduced GFR, then this oxypurinol accumulates, and most of the side effect of allopurinol are because of oxypurinol. Even oxypurinol itself can cause stones. Forget about uric acid. Oxypurinol, it can cause kidney stones. And oxypurinol is known to cause a tubulointerstitial nephritis. Means what is tubulointerstitial nephritis? It is an allergy limited to kidneys. Just like if we take some drug, we can have a drug allergy or a Steven Johnson in if severe. So similarly, it just the allergy which is limited to the kidneys, which can increase the creatinine and cause acute kidney injury. So practically all allergic complications are there associated with allopurinol, and they are more if the byproduct is accumulated, and this byproduct accumulates if the GFR is low, as it is not excreted nicely. So that's why in CKD we have to be cautious. We cannot start with 100 milligram TDS. We have to start with 50 BD, then slowly increase if the patient tolerates. So it can vary from just a minor skin rash. It can be a severe hepatotoxicity. It can be a full-blown Steven Johnson syndrome. So you have to be cautious after starting the medicine, and you should inform the patient about the same. It can cause tubulointerstitial nephritis also. While for febuxostat, as far as the safety profile is concerned, efficacy is more or less equal. But as far as safety profile is concerned, it fast slightly better when the GFR is reduced because there is no accumulation as such. But still nausea, hypersensitivity reaction, and deranged LFT. So obviously, if someone is having transaminitis existing, then you should be cautious while starting the febuxostat. So effects of xanthine oxidase inhibitor on renal function, blood pressure, and hypertensive patient with a hyperuricemia. So we will just go through the few slides of studies and researches. We will not go into the details. Even I have not seen in between the things. But what is the basic thing I want to convey is uh, here they were started. The patients were the sample size was started on the allopurinol or febuxostat treatment, and the endpoints were serum uric acid levels, estimated GFR, and blood pressure, which were compared in the two groups, allopurinol versus febuxostat. So obviously, both xanthine oxidase inhibitors significantly reduce the uric acid level. That is the efficacy of both drugs. The uric acid levels were more than 6 in 29% of total patient and 32% patient in febuxostat, while 27% in allopurinol. Not much difference, but 32% achieved less than 6 level, which is required in some difficult gout and uric acid stone patients. And while 27 or 28% of the allopurinol patients showed this result of giving a uric acid level less than 6. The eGFR decreased by 1.9 ml before initiating xanthine oxidase inhibitor and increase after starting the treatment. So basically a renoprotective effect, which is irrespective of reducing the uric acid level. Why? By reducing uric acid level, it reduces the oxidative stress in the kidneys, and by other mechanisms also, it prevents the or preserves the GFR. So this second thing, comparison of uric acid reduction and renal outcomes of febuxostat and allopurinol in a patient with existing chronic kidney disease. So again, half of patients who were having existing CKD were watched for 2.5 years on febuxostat versus allopurinol, and the outcomes which were targeted were serum uric acid level and GFR reduction. So the conclusion was febuxostat did better to allopurinol on sustained reduction of serum uric acid levels with CKD patients. Comparison of long-term efficacy and renal safety of febuxostat versus allopurinol. So again, it is grouped, and the cardiovascular and renal functions were assessed. So study revealed that febuxostat was more effective than allopurinol in reducing serum uric acid levels. The result showed that in patients with CKD and hyperuricemia, febuxostat can be used to reduce serum uric acid level, which is slightly better than the allopurinol. And the long-term use of febuxostat may exert a protective effect on kidneys, not just by reducing uric acid, but itself an individual property to have a renoprotective effect as compared to allopurinol. And no obvious adverse reaction happened, and the drugs were tolerated well. Effectiveness of febuxostat in patient with allopurinol refractory hyperuricemic chronic kidney disease. This is something interesting. Now, there are two things. First, we will go through this. So, the results were कि febuxostat treatment significantly lowered the serum uric acid level and response rates were 70% at all point of 1 year. History of gout attack decrease and no adverse events. So, febuxostat effectively lowered serum uric acid levels and was well tolerated in CKD and allopurinol refractory hyperuricemia. Now, here are two things. Here there are two things. First is in CKD, giving allopurinol, we have to be quite cautious. As I said, there is accumulation of a metabolite that is oxypurinol that itself can cause kidney stones and worsen the CKD. That itself can cause allergic interstitial nephritis and worsen the CKD, or it can cause a AKI. So obviously, whenever it is existing CKD, then most of nephrologists, I think, will be more will feel more safe while using febuxostat, which can be given even 80 milligrams, while giving allopurinol and increasing the dose. The maximum which is required sometimes is 800 milligrams. So in reduced GFR, especially advanced CKDs like stage 3, 4, 5, the safety of allopurinol is likely a concern. So febuxostat and cardiovascular safety. So previously, in initial studies, it was found that febuxostat has some cardiovascular side effects or endpoints which were not very favorable. But after this fast trial, which was an open label, double-blinded trial, so the risk factors were taken care. That was the patients were 60 years and old, already receiving allopurinol, and had one cardiovascular risk factor. So febuxostat is non-inferior to allopurinol therapy with respect to primary cardiovascular endpoints. Cardiovascular side effects were not more in febuxostat group also as compared to allopurinol. So no serious side effects were noted with a febuxostat also as far as cardiovascular outcomes are concerned. So basically, the summary of today's talk is uh, there is a growing evidence that hyperuricemia with or without deposition means crystallopathy is associated with both cardiovascular risk or CV event as a factor of as one of the factors of a metabolic syndrome that we know, that is all obesity, diabetes, cardiovascular risk, hyperuricemia. So associated cardiovascular risk and decline of renal function. So forget about the crystallopathy, the gout and the renal stone. But there is a growing evidence that hyperuricemia, asymptomatic hyperuricemia, itself can be linked to a worsening factor in a metabolic syndrome. Abundance of experimental and clinical data available suggesting that hyperuricemia may accelerate the kidney damage that we have discussed. Many clinical studies have provided support to the hypothesis that using the uric acid lowering therapy may be beneficial in preventing and delaying a decline in renal functions in CKD. Uric acid lowering with xanthine oxidase inhibitor should be considered as a therapeutic option in patients at high renal risk or a declining renal function with hyperuricemia without crystallopathy. Febuxostat has a stronger uric acid lowering effect, renoprotective effect, antioxidant effect, and anti-atherogenic effect than allopurinol. Evidence available for long-term use of febuxostat proves that it may exert a protective effect in knees without adverse reaction, and drug is well tolerated. Comparative studies suggested that febuxostat is more effective than allopurinol and topiroxostat in halting the progression of CKD. There were concerns regarding cardiovascular safety of febuxostat in early clinical trials, but now it is well established that febuxostat initiation was not associated with higher cardiovascular risk, including the cardiovascular or all-cause mortality compared with allopurinol. Thank you.
Thank you so much, sir. So there are few questions that I would like you to address. We have received it during the session itself. So one
Sure.
is like a lot of young physicians and nephrologists have joined us today. So wanted you to address that. What is the most common gap that you have, experienced in the management of hyperuricemia, and how it can be overcome into the day-to-day practice?
Okay. So basically, whenever it is hyperuricemia, as I told, whenever it is about dealing hyperuricemia with a crystallopathy, that is a proper uric acid kidney stone or a gout episode, then it is very easy to understand that here I have to keep the uric acid level controlled, and preferably less than 6 should be the target, which is well known fact. But the question comes whenever there is no symptomatic hyperuricemia, no crystallopathy, but the levels are above the reference range, means somewhere between 7 to 10. Usually, what we do is about 10, you should go for a treatment. You should not wait for a crystallopathy to happen. And neither the unknown factors that we have seen through all through our presentation, that increase CV risk and other risk. So you should not wait for that more than 10. I will say go for treatment. Crystallopathy, go for treatment. The gray zone is somewhere between 6 to 10. So now, usually, whenever we advise as a nephrologist, we just advise a renal function test, a complete renal function test, which gives me a result which gives creatinine, serum electrolytes, calcium, phosphorus, and there is a someone sitting at the bottom of the report, that is the uric acid level. So this uric acid, if it comes somewhere between, the whether to treat it or not. So this is the crux of the story today. So basically, as far as 6 to 10 is concerned, so I will say two things. First, in my personal experience and as per the studies and researches, 6 to 10 usually does not require the treatment unless and until crystallopathy is there. Second thing, even if you want to treat, there is no contraindication as such. Obviously, you see that whenever you are starting a therapy for the same, then you are not doing the harm more than the benefit. So obviously, the individual patient profile has to be seen, and accordingly the uric acid lowering therapy has to be started. As we have discussed, if someone is already having some underlying liver issue and he is not having a proper crystallopathy out of uric acid, so treating 6 to 10 uric acid and again straining or stressing the liver is not a good idea. This is what I think. So it has to be the therapy for asymptomatic hyperuricemia is to be individualized as per the patient basis. This should be the thing that we should do.
Okay, sir. So this brings me to a very next question, which is associated to the first question itself. For the patients who have a comorbidity or cardiovascular risk associated, do you have any advice with regard to the dose adjustment, and what should be the duration of treatment, and how often they should check the uric acid level?
Okay, so basically, whenever the uric acid lowering therapy is started for a crystallopathy, then it should be kept as low as possible. Means if less than 6 or 7.5 or at least 6, if possible, then that should be tried first of all. Second thing, if it is started for something which is a asymptomatic hyperuricemia, just like you said, ki cardiovascular causes and all. So for cardiovascular risk, I will say obviously start for about 10, not below that. But once you start, then the dosing has to be titrated as per, means once you start the therapy, you have to monitor uric acid level at least 2 to 3 weekly. And then you up titrate the dose of febuxostat as well as allopurinol. Allopurinol to start with, you can start with a 100 milligram BD or something like that, considering the individual risk factor. And if the patient tolerates that well, and still the target is not achieved, then you can always go up to 800 milligrams in a day as far as allopurinol is concerned. As far as febuxostat is concerned, you increase it in 2 to 3 week span or even a monthly span to reach to 80 milligrams, which is a maximum allowable dose for a, yeah. For topiroxostat, it is 40 milligram as far as per my knowledge. So you have to reach to that maximum dose which can be tolerated without side effects, and the purpose of reducing the uric acid or the target of less than 7 is achieved. And that dose, I don't think any physician will say कि uric acid hyperuricemic drug has to be stopped. Once that is started, usually we don't discontinue it unless and until there is any other side effect. Because one thing, it is solving the purpose of treating crystallopathy. Second thing, by unknown mechanism, it is also solving the purpose of reducing the metabolic syndrome or a CV risk in total. And third thing, if it is not causing any harm or side effect in long term also, if it is tolerated well by patient, there is no role of stopping the uric acid therapy. Just like a atorvastatin, just like a statin, we don't stop once we start it. So usually uric acid therapy can be continued lifelong once it is started. And as far as the other question was, the dosing as per the patient's profile. So obviously, in later stages of CKD, we don't use the doses of 80 milligrams for febuxostat. Usually we settle to 40 milligram. And as far as allopurinol is concerned, so we have to be very cautious. So there is no exact guideline ki how much creatinine or GFR the dose should be. But usually we don't go for more than 100 milligrams TDS for later stages of CKD, that is for sure. And even 100 milligram BD is okay, but not to 800 milligrams and all, which can be used for a normal creatinine patient.
So, in your presentation, we saw that asymptomatic hyperuricemia. It has been a quite a lot of debate around the asymptomatic
Yes.
hyperuricemia to treat or not to treat. So, especially when it comes to a nephrologist, what is your practical opinion? Like when a patient associated with CKD comes with hyper elevated uric acid level.
So basically, as I previously said, if there is a asymptomatic hyperuricemia, uh, treat it if it is more than 9 or more than 10. More than 10, you should surely treat, because even if patient is not having any crystallopathy now, he may have it in future. So why to wait for it if you have a such safe medicines available to, and safe and easily available, and not very costly medicines available to treat it. So if it is more than 10, I don't think there should be any dilemma to treat the hyperuricemia, even if it is a asymptomatic one. Second thing, someone who is already having a uric acid level of 10 and is supposed to be started on a anti-tubercular therapy, first line therapy, where pyrazinamide is there. If someone is already being started on a diuretic therapy, like whatever, furosemide or a torsemide, then it is expected that uric acid has to go up. So waiting there, I don't think will be a great idea. And in that case, means anything above 9 or 10, I think we should start uric acid lowering therapy, even if it is asymptomatic. And if you anticipate that with some other conditions, it is going to be go up, like other condition like a malignancy. If the patient is having a significant malignancy burden, and if he is supposed to undergo chemotherapy, after this chemo, there will be a huge cell lysis, and this cell lysis will 100% cause a hyperuricemia, and that can be so detrimental. It can cause a tumor lysis syndrome and acute kidney injury and whatnot. So why to wait for that? So before starting that, you should start a uric acid lowering agent, I guess.
Rightly mentioned, sir. And especially the patients who are under diuretic therapy for long term also. So one of the side effect of it is also the hyperuricemia. So you think, sir, in cases where there is diuretic which has already been added, the patient should be given
Uh,
febuxostat?
Not in every case, but after starting that, the dictum is कि you should monitor the uric acid level in next visit. Not just the diuretic is supposed to be given for a diuresis, means not just the edema. You should also check for other things, creatinine, electrolyte. Electrolyte also you check after starting diuretic, because there can be a dyselectrolytemia, it can be hyperkalemia, hypokalemia, or hyponatremia, many things. So similarly, as you see the swelling has gone or not after starting diuretic, as you check electrolyte, as you check creatinine, you should check a uric acid also. And if it is more than 10 or a 9, I think you should start the uric acid therapy simultaneously.
Okay, sir. I think this has bring us close to the end of the session. And I would like to share to the audience that the session is available on YouTube. We'll have the recorded version available on YouTube, and you can go and like it, share, comment, and subscribe. Wherever you think that there is any feedback or any question to be asked, you can share it across. And with this, I would like to propose a vote of thanks to Dr. Rahul Deshpande, sir. Sir, on behalf of Saffron Formulations, I, Anjali, would like to propose a vote of thanks for sharing your insights and a very practical opinion on the management of hyperuricemia. And I'm sure this is very useful for the doctors in their practical day to day management of the patients who are going through such conditions. Looking forward to your continued support and guidance, sir.
Thank you. Thank you very much, sir, for such a wonderful program. It was nice to interact with all you.
Thank you, sir. Thanks a lot.